Good morning, everyone. So my name is James Montgomery. I've got a background in operational and business management in different acutes in the NHS. And I've got the unenviable task of following Mike and talking to you about the exciting topic of NHS funding. So what I want to do is just build on a little bit of what Mike touched on there in terms of how funding flows through the NHS system, so give a bit of an oversight and a very high level view on the structure of the NHS. And then I'm going to go into a little bit of detail around some of the internal methodologies and processes used by trusts that hopefully you can draw that information from and apply to your products, your devices, and get a sense of how you may then interact with the system as a whole. The reason for that, I think as Mike touched on there, is that accessing the NHS is a complex, large-scale industry made up of multiple individual organisations that act, behave, are structured completely differently. It's a complex challenge, and accessing that funding, getting your product, fulfilling the 4Ps, getting the product that is beneficial to patients into a system and increasing the adoption rates, which are historically very low, is a big challenge. In terms of the flow of money, therefore, if I'm going to set out from the high level perspective and drill down, just to give that kind of semblance, that structure. As Mike said, we start with NHS England, who receive an annual budget, and the bulk of that budget goes to commissioners, CCGs, who are responsible for purchasing approximately £80 billion worth of services from these four types of providers. We've then got two quite significant separate streams in primary care and specialist services, which may or may not apply to your companies. The bulk sits with CCGs. We've then also, in latter years, and including in this year, we've then got three kind of quite distinct pots of money which allude to strategic direction and strategic aims that the NHS are working towards. What I want to do then is funnel down further. So we had NHS England at the top. That £80 billion is national, and if we take one chunk of the country in terms of Mid and South Essex, a local system, one of the 44 sustainability partnerships that's been established, and within this area, we've got 5 of those CCGs who will have an allocation of that 80 billion, and they will essentially act as the purchasers of healthcare from 3 trusts spread across 6 hospitals and working with 1 ambulance service. The reason to give that is really to give that context. Within that population, we've got a pot of money spread amongst 5 commissioning groups, probably loosely aligned, so 1 or 2 of those CCGs will have very strong contractual links with 1 or 2 hospitals, and that purchaser-provider arrangement is in place there. If we drill down slightly further then and take one of those hospitals, I think Southend from memory, something that you'll start to recognise, because just as within the whole NHS structure we've got a flow of money and we've got segmentation between someone who provides services, someone who pays for services, and by extension different potential customers from your products or for your products. We've also got that within a hospital, so there's a stab here at structuring a hospital, segmenting it into a sensible arrangement, in this case 6 different directorates really, in a way in which they can then manage internally. We take one of those directorates and drill down further. We've got a standard line of management, and again, segmentation. So what you may start to see, just as you may start to see in your interactions with providers, with procurement, with commissioners, the person that you are potentially looking to purchase your product is not necessarily the one that would deliver the treatment. If you're looking to promote your new urology scope used in outpatients, in this hospital, actually outpatients may well be purchasing, but the benefit will sit with urology. The treatment efficiencies, the patient improvements, the clinical engagement, the clinical interaction, all of that income will all sit with urology rather than with outpatients. Again, in an internal basis, that split between who pays and who benefits. So I wanted to give that context really just as a frame, so that when you see, read, interact with hospitals, you understand the kind of national, the very high level, but the national context and framework in which they operate. If we then move actually just specifically to internally within hospitals, the income and the coding and the accountancy and the procurement are all bundled together, and particularly important for devices and for medical technology, because coding essentially drives income. A bit like with healthcare in general, if it wasn't written down, if it wasn't recorded, it didn't happen. It's similar with finances and with the activity. If it wasn't captured in codes, it didn't exist for an income purpose. And if you're looking to drive sales, to access money, access funds from a hospital, it needs to have been recorded to link to that income that they will deliver or they will gain. In terms of coding, there's very kind of 3 clear steps. It all starts with what's called Opcs Codes, a set of very accurate clinical-based codes which record diagnoses, they record interventions, they record procedures. So anytime anyone does something to a patient in hospital, from an intervention perspective, that should be recorded. They are bundled together to create a tariff, and it is that tariff which is aggregated at a patient level detail. All of the activity that takes place is aggregated and is essentially sent to Commissioner through something called sus data, which is basically the hospital's invoice. And in return for that, they will receive payment. Now, what that means, and one of the important things around that, is that recognising that activity forms a key part of the first of these 3 blocks around how trusts manage their finances and how the money flows internally both into the trust and then out of it. The first part is around the income plan. So all of that activity that's coded forms the basis of a forecast, essentially. So an annual forecast that predicts the type of procedure that's going to take place, the volume, the income that will attract, and that forms a contractual agreement between the trust and the CCG. It's a commitment by the CCG that they anticipate paying over the next 12 months a certain amount of money based on this forecast activity, and it's a commitment by the trust that is what they will probably work to deliver. On the flip side to that, and this is something we'll come on to in terms of expenditure and the trust position, we've got that income plan, we've then got an expenditure budget, that is how the trust will look to manage its finances. It allows some element of specialty control. So we go back to the hospital structure that I showed earlier. What you'll see, most hospitals will then have a series of specialty budgets, so that each specialty has some semblance of control over the activity that it does and the way in which it works in year. It will allow procurement to access those budgets and vice versa. Procurement will have its own budgets, its own targets, its own efficiencies and so on. And again, we'll have a way of managing its spend in year. And it allows the trust to segment by type of cost. So pay, non-pay, and within non-pay you can then have maintenance, equipment, drugs and so on. And it's probably one of the kind of key distinction at this point is that type of cost, drug spend for example, would very much focus on being in an expenditure budget, whereas costs associated with adopting a new medical device, for example, you potentially need to look more down the route of linking that to the income that it delivers and applying that cost directly to that so that you can justify that to the trust. You can meet that P where the payer benefits and then meet the other P's in terms of the patient satisfaction, provider and so on separately. Those two, the income plan and the expenditure budgets, combine to allow the trust to manage its in-year position. And this goes 2 ways. So firstly, there was the internal management, so the trust will use that to manage how they are performing in year, as any business would, and to track activity, track performance, track progress, track the performance of each department. But it also allows the trust in turn to be managed externally. So just as we saw the money flow down, so too does the authority and the responsibility. So accessing the early slide around the NHS England picture, there's £2 billion allocated for something called provider sustainability. That's essentially a an incentive, a financial incentive for trusts to manage their position in year well and access some of that funds. So there are levers in place for top-down management. And the reason I'm making a point around this is that in-year financial position and performance and the very small micro-level adjustments and scrutiny that trusts often take support the position, as you may well see, or your sales teams may well have seen, that the immediate response from procurement or from anyone who's not a clinician in some cases, so they get the clinical engagement, but then actually the business manager, the procurement manager, facilities, estates, whoever it may be, the immediate response is around short-term efficiency gains or short-term cash releasing, rather than that longer-term transformation where your product could genuinely make a massive radical difference and improvement to a patient, if only it was given the headspace to develop and to deliver that, crossing organisational boundaries or moving away from that short-term cash-releasing focus. So what I wanted to do, just conscious of time, is just to finish by just highlighting sort of five of the key concepts or principles that I've discussed. Ultimately, the primary point is that CCGs fund activity. They fund the bulk of activity, and they pay hospitals for the work that they perform. So if your product is cheap, fantastic, because there's a direct benefit and enhancement to hospitals because you can cut costs. If your product increases efficiency or throughput, then potentially that's very promising because it increases the hospital's margin. If your product actually cuts hospital attendances, cuts admissions, cuts activity in some way, then ironically enough, that's a perverse incentive for hospitals currently. Hospitals have a way of segmenting their structure, so the department that pays for your product may not be the one that uses it or benefits from it, and again you have that mini internal battle debate just as you have between organisations. Ultimately, new technology should or will ideally link to a specific procedure, because otherwise it's the cost of doing business. If it can be linked to a procedure, you can demonstrate the increased income, the increased activity, and the increased benefits that product delivers. If not, it's a cost. Drugs are a cost of doing business, or a cost of having patients on wards, or coming in through A&E, or being operated on, and they sit in budgets often. In contrast, you could link directly to a procedure and have a different type of conversation around price. Budget management, as I say, regardless of the type of budget, regardless of whether it's the conversation with SID in procurement or a business manager or a clinician with purchasing power, it is still going to affect that in-year performance, that in-year position. And on the one hand, for small cost, small volume, whatever it may be, that's potentially quite flexible. For large or moving into capital purchases, something significant, you start to potentially raise a block purely for the funding flow and the financial structure. But finally, integration. I touched on it through the position around Essex and that focus on a health system, and potentially what we're seeing with NHS at the moment is an attempt to move away from those funding flows that we've talked through, those top-down, structured, segmented flows, to something that's much more integrated. So you start to see, when you've got a product that's got real benefits around prevention or around avoiding admission or patient self-care, actually the NHS is starting to set itself up so that it can support that innovative whole pathway development and work, rather than is it something that directly affects a patient in hospital, and in theory could or should start to increase the level of adoption and make that process by which you engage with systems slightly easier, ironically, as the healthcare environment becomes a little bit more complex. So thank you. I appreciate there's a lot to bombard you with in that top level structure, but hopefully that's a taster of some of the ways in which the NHS structures itself.
Thank you, James.